Epidemiological characterization of high-risk cardiovascular factors using data collected by a smart health kiosk in participants of the Tu Corazón project, an intergender analysis through artificial intelligence strategies. Today, in both Mexico and the world, we are dealing with health challenges such as overweight and obesity, diabetes, high blood pressure, hyperlipidemia, cardiovascular disease, cancer, and mental disorders. These challenges are caused both for the current demographic change of the population, which is the inversion of the population pyramid. There are more adults than kids and adolescents and teenagers, and in addition with that, it's the adoption of unhealthy habits such as sedentarism, poor diet, smoking, alcohol consumption. The importance of be aware of these causes is because the first one, the one related to the demographic change in the population, it's because both adults and seniors are more likely to suffer from metabolic related diseases. Uh, on the other hand, the adoption of unhealthy habits, which we had mentioned earlier, increase the risk of this kind of diseases. The worldwide status respecting cardiovascular disease, also known as CVDs, are really worrying. The World Health Organization estimates that currently the CVDs are the main death cause, causing around 17.3 million deaths each year. The cardiovascular disease involve the circulatory system, which are the heart and the blood vessels. Some of the examples are the coronary heart disease, also known as a heart attack, the cerebrovascular diseases, such as the strokes, and other events such as the pulmonary embolism and the deep vein thrombosis. It is important to know that the cause of the cardiovascular diseases, it is usually one of the following. It's either an obstruction produced in the blood vessels or an hemorrhage. So such is the case of the strokes. In the case of the obstruction, it is often due to atherosclerosis, which is the famous plaque caused by both triglycerides and cholesterol in the blood, which, due to the poor blood flow through the body, there is an imbalance between the supply and the necessity of the oxygen, which leads to anoxia, which is a low concentration of oxygen in the blood, which could be resulting to a cardiovascular event such as a heart attack or a cerebrovascular disease. As we mentioned it earlier, there are risk factors linked to the CVDs. Some of them are behavioral and some of them are clinical. And usually the behavioral are a direct cause of the clinical factors. What are the cardiovascular risk factors? According to the Framingham Health Studies, these are a measurable element or characteristic that is causally related to an increase in the frequency of a disease, and it constitutes an independent and significant predictive factor of the risk of contracting that disease. There are two kinds of factors, the behavioral and the clinical ones. The behavioral factors are things such as smoking, eating inappropriately, not exercising, and consuming harmful quantities of alcohol. In contrast, the clinical factors are usually caused by the behavioral ones and are biological indicators like high blood pressure, diabetes mellitus, and hyperlipidemia. On the other hand, there are factors that decrease the risk of contracting CVD, such as quitting smoking, reducing salt and alcohol consumption, start exercising, and the consumption of fruits and vegetables, which are reflected in clinical factors such as normal high blood pressure, normal glycemia, also known as normal levels of glucose in the blood, and normal lipidemia. It's the same, normal levels of fats in the blood. Now, these risk factors are useful, though they are used for the assessment of the cardiovascular risk of an individual. Through history, there have been a lot of models, such as the Framingham studies, the score, which is used in Europe, and the algorithm that it was developed by the American College of Cardiology and the American Cardiology Association, which is derived from studies like the Framingham one, and they are really useful. Respecting the cardiovascular disease status in Mexico, there has been an increase in obesity, hypercholesterolemia, arterial hypertension, and metabolic syndrome, which had led to an increase in the cardiovascular disease proportion. Due to this, there has been proposals, both public and private, to generate awareness of this kind of diseases. For example, the CCC has designed a kiosk, also called a Smart Health Kiosk, or KISS for its name in Spanish, which is Kiosco Inteligente de la Salud, which is its purpose is generate health awareness, promote the prevention of CVDs, recollect somatometric, clinical, and behavioral data regarding their users, and it's based in the algorithm previously mentioned of the American College of Cardiology. Derived of this development, Upjohn, which is a subdivision of Pfizer, has started a project which is called Tu Corazón, for your heart, which its main purpose is to generate awareness strategies respecting disabilities in the workplace. Its scope is the working population, people between 30 and 74 years, in the cities of Guadalajara, Monterrey, and Mexico City. And its population sample will be of 15,000 people. For this project, electronic medical records are used. They are part of the big data, and despite its difficulty of being used for the health professionals, they have certain advantages, such as the analysis, interpretation, and transformation of the information, which will acquire clinical value. This allows to do research in a scope that is rarely accomplished in the medical field. Well, the development of new technologies for even healthcare automatization and other qualities make the EMR a very unexploited tool in this field. For the analysis of the data, it is used artificial intelligence. There are a number of examples, such as artificial neural network, or ANN, and machine learning. The machine learning has the potential of processing immense quantities of data and to be trained with the use of millions of records without attention gaps. This is very useful because it eliminates the human error. Additionally, it provides comprehensive solutions for multi-view data. As well, it generates predictive models with specific requirements by extracting and learning from patterns in the data. This is very useful because there are certain patterns that the humans cannot detect when they are analyzed manually, the data. On the other hand, the artificial neural network, it actually is getting to another level because it allows a learning capacity due to the multi-layer neural networks with a superior performance than even traditional ML techniques. Furthermore, some statistical features are required to analyze these enormous quantities of data. There are certain techniques that are used, such as the mean square error or the mean absolute relative difference. Also, there are the area under the receiver operating characteristic curve, or AROC, and the Matthew correlation coefficient values and the Clark-Error grid. The former allows to return values in the range between -1 and 1 according to its prediction accuracy. On the other hand, the Clark-Error grid assesses the clinical significance of the deviation from estimated values. The justification of this study is to predict the future based on the mathematical algorithms, following prospective studies to predict that individuals will develop cardiovascular disease through their lives in a predetermined period, also known as cardiovascular risk. This is important because CVDs are the main causes of morbidity and mortality in Mexico. The main problem to resolve is what are the main factors associated with the presence of cardiovascular risk, high, medium, or low, in workers from various institutions in Mexico that participate in the Tu Corazón project. This is pivotal as an start for this project due to its usefulness on showing the cardiovascular state in the population, specifically in the working population. The main objective is to establish the initial outcome of the Tu Corazón project, respecting of the CVD's health position on the work environment from diverse institutions with the information collected with the smart health kiosks, the kiosk, in a sample of 734 persons. As I mentioned it previously, this is pivotal because it may be an important indicator of which is the direction that these studies will follow. This project doesn't have its challenge. The collection of the real-world data using large protocols can be buggy, and the data obtained maybe show missing data and erroneous information. That's why it's important to process the data first before we can use it to our statistical estimates. The data collected for this project is retrospective during the Tu Corazón project capture period, where all patients' identification information is rendered anonymously before the data is provided to the researchers. These data include demographic information, anthropometric values, clinical laboratory measurements, and some relevant clinical aspects. In addition of this individual data, there is a calculation of the cardiovascular risk of each patient. As we can see, multiple features will be considered for the calculations and the algorithmic estimates. First, the data must be sorted and then processed to have both individual and overall estimates respecting the cardiovascular risk. As we mentioned earlier, the sample will be of 734 individuals participating in the initial phase of this project, which will be constituted by adults between 30 and 74 years from various areas of Mexico. These people will be from both public and private institutions, and they will be participating voluntarily to this project. The calculation is based on the number of variables and observations of these variables, proposing as a minimum requiring the existence of 10 observations for each variable. The result shows that the population is very fairly distributed between males and females. As we can see, the population has a very diverse set of variables regarding their age and their clinical features. As we can see in the clinical features separated between sexes, there is a difference of some significance. Even if the males are slightly older than the females in the average age, the cardiovascular age which is an indicator of cardiovascular risk, are more, much higher in the males than in the females. As we can see, another data has been collected regarding both behavioral and clinical features, which are linked with cardiovascular risk. The information previously mentioned was also segregated between males and females. And even if we can see a slight difference between them, they are not different enough to justify the difference between cardiovascular ages. As we can see, the difference between males and females is more explicit when we see the difference between the cardiovascular age and the chronological age of each individual. Proportionally, the male population has a greater proportion of people with cardiovascular age greater than their chronological one, which is an indicator of cardiovascular risk, being of 43.5% in comparison with the female ones, which is only 17.8%. The following table shows us a student distribution analysis regarding the populations between males and females, and it indicates that in each of the features between males and females there is a significant difference, and both populations, at least in these measured features, are significantly distinct between them. As we can see, these results indicate that there is a difference between the cardiovascular age between males and females, showing that the male population, at least in the Mexican work environment, it has a higher risk of suffering a CVD. There are multiple factors that could be acting respecting this gender gap. Respecting the behavioral factors, men are less likely to participate and endure in dieting to lose weight in comparison with women. This is reflected in the fact that men are twice as likely of suffering a myocardial infarction in regard of women. On the other hand, estrogens may provide protection against cardiovascular diseases. This is confirmed by the fact that postmenopausal women undergoing hormone replacement treatment has 50% less risk of having a coronary event in comparison that postmenopausal women that are not undergoing of hormone replace treatment. Regardless of if the cause is either biological or behavioral, the importance of studying and considering the gender gap respecting cardiovascular risk is pivotal to improve the healthcare provided to people in the work environment. In conclusion, the data reveals that there is a difference between genders regarding cardiovascular risk, being significantly higher in men than in women. Additionally, all the risk factors respecting cardiovascular disease are higher in men than in women, hinting that to be the cause of the cardiovascular risk difference between genders. However, further research must be done regarding these to have either a biological cause, such as estrogen protective role in the CVDs, or if there is a behavioral aspect between men and females that could tip the balance regarding this issue. Moreover, there may There may be both biological and behavioral aspects respecting this difference, which means that a more wholesome approach regarding cardiovascular risk and cardiovascular prevention should be applied. Thank you for